Endovascular coiling of ruptured 3.5 millimeter anterior communicating artery aneurysm, February 2012. The surgeon and the narrator, Dr. Michael Horowitz. Here we see an arteriogram with an anterior communicating artery aneurysm in the center of the screen. This is a road-mapped view of the right common internal and external carotid arteries. A wire is advanced from the groin up through and into the right internal carotid artery. A 6 French guide catheter is then advanced over the wire and positioned within the cervical segment of the right internal carotid artery. Through this guide catheter, a smaller microcatheter over a very small 0.010 inch wire is advanced. It is advanced up into the intracranial portion of the right internal carotid artery. The wire is manipulated to steer through the vessels around the various turns into the different branches. Here, the wire is being advanced into the right anterior cerebral artery, and the catheter is being placed over it. The wire is now drawn back, and the catheter will be advanced into the anterior communicating artery aneurysm. Here it is positioned within the aneurysm. The steering wire is now removed. The first platinum coil is advanced through the catheter and will be manipulated in place and positioned within the aneurysm. This is a wide-necked aneurysm, meaning the opening of the aneurysm is fairly broad, making it difficult for the coils to stay within the aneurysm. For this reason, we will be using what we term a dual catheter technique. This technique requires placement of a second microcatheter into the aneurysm. During treatment, therefore, we will have 2 catheters within the aneurysm and will be advancing coils through both catheters into the aneurysm. This provides increased stability for the catheters and coils, allowing us to treat wider necked aneurysms without using alternative means. Here the first coil is being advanced through the first catheter and it has been placed into the aneurysm. The coil has not been released. A second catheter is now advanced over a micro wire. This second catheter will also be placed within the aneurysm. Therefore, during this coiling procedure, we will have 2 catheters within the aneurysm at the same time and will be advancing coils through both catheters. Here the second catheter tip is placed into the aneurysm and the micro wire is removed. A coil is now placed through this second catheter and into the aneurysm. This coil will be manipulated numerous times until it locks itself into place within the aneurysm and into the previously placed coils. This allows the coils to stay within the wide-necked aneurysm. You'll notice several different manipulations of the wire and catheter and coil until the coil decides to assume a position in the aneurysm where it cannot herniate out of the aneurysm into the normal vessels. The coil is withdrawn and is going to be re-advanced until we have satisfactory placement. The coil has now been satisfactorily placed within the aneurysm. An arteriographic run is done. This shows reduced filling of the aneurysm with contrast and blood. The coils are in good position. One of the coils is now released and being removed from one of the catheters. The catheter is left in place in the aneurysm, so additional coils can be placed. Another coil is now being placed into the aneurysm to further fill it. Another injection of dye is done, and we can see that the aneurysm is filling less with blood and contrast at this point than it was previously. One catheter has been removed. The second catheter is removed after its coil is released. This coil did not completely release, and it is being released again. The delivery wire is now removed. An arteriographic run shows good treatment of the aneurysm. The second catheter is now removed. The coils remain in the aneurysm, and the microcatheters have been removed from the body. A final arteriographic run will be done, showing our completed result. This concludes the procedure.